of fever and vomiting for the last 1 day, and alteration in her blood glucose level for the last 12 hours. She was in her usual state of health 1 day ago when she developed fever, which was gradual in onset, progressive, ranging up to 102 degrees centigrade Fahrenheit, which was measured by the mother herself and by the auxiliary thermometer, and it was partially relieved by the paracetamol. It was not associated with any fits or ear discharge or any productive cough. She also complained of vomiting, which was gradual in onset, 7 to 8 episodes per day, containing food particles, non-projectile, and for which mother took some antiemetics as well, but it wasn't relieved. Mother, who is well aware of her diabetes, checked her blood sugar levels as per routine at 7 times and noticed that her last three blood sugar levels were in the range of 300 to 400. It was checked by the same glucometer. She was then taken to a nearby hospital in Narowal, where she was investigated in the form of urinary ketones, and they came out to be +2. And due to non-availability of other investigations, she was told to have some checkup for her DK, for suspected DKA. So she came to Children's Hospital Lahore, where she was investigated in the form of extensive blood tests and urine tests, and it came out in favor of mild decay, and she was given insulin and fluid therapy for 12 hours with a good improvement in her vomiting and fever, which stopped, and also her blood sugar levels optimized between the ranges of 150 to 200 milligram per deciliter. She was then switched on to subcut insulin and was started on her uh, current basal bolus regime insulin, which was 5 units regular in the morning and 3 units in the evening and night, and 10 units of the basal insulin at night time. Actual history dates back to 1 year ago when Maheen developed polyuria, polyphagia, and decreased weight loss ranging up to 3 kgs in 10 days, and it was noticed by the mother. There was no history of head trauma and bedwetting or burning maturation. And there was also no history of abdominal pain, surgery, and repeated chest infections or long-standing medication intake or any bony deformities. She was then taken to multiple clinics, and with no diagnosis being made, she presented to Sahara Hospital, Narowal, where extensive investigations were done in the form of blood tests and urine tests, and diagnosis of severe DKA was made, and a protocol was started for 48 hours. However, after 12 hours of onset of the symptoms, she developed a black spot on the right inner canthus of her eyes, which rapidly progressed to initially ecchymotic changes on within 12 hours of presentation, and later on to some serous sanguineous discharge after another 12, approximately 12 to 24 hours. So with she was referred to Children's Hospital Lahore for the first time with suspicion of some orbital cellulitis. Here, multiple investigations was done, and in the form of blood test, urine test, neuroimaging, HbA1c, and MRI orbit and brain was also done, which showed brain abscess and orbital cellulitis. It encompassed the right eye with involvement of the optic nerves, some brain abscesses in the frontal and the temporal and the occipital lobes as well, and there was also involvement of the ethmoid sinus and the right part of the nose. So patient was started on the DK protocol and was started on amphotericin, which was initially started 15 gram OD for first 4 weeks. After 4 weeks, when there was she was also put on some evaluation for the with the eye doctors, and after 4 weeks, enucleation, extensive enucleation of her right eye along with the optic nerve was done, and also neurosurgery team, they removed part of the ethmoid bone, and the through the same port they removed the frontal abscesses as well. After that, the child remained admitted for total of 3 months, and during this time she suffered from complications of the surgery in the form of loss of speech and hemiparesis of her right part of the body, and hemiparesis of her left side of the body. The child was then, the mother was then shifted to the endocrinology ward, and she was taught about the insulin storage, administration, its carriage, and the complications that might arise. And she's well aware of that and is quite compliant with the diet and the insulin and the exercise. After 4 weeks, the child, there was little or no improvement in the uh, in her brain abscesses on a follow-up MRI, and so the uh, amphotericin regime was successfully extended, first till 3 months total, and then till 6 months. While after the initial 3 months, the child got discharged. The child came on regular follow-ups, and where she was followed up on the basis of MRI of the brain and orbit, regular eye visits, and she was also having serial RFTs and serum electrolytes to check for the amphotericin toxicity. 6 months after the start of the amphotericin, child's RFTs were deranged, and she was then switched on to alternate day regime of 20 gram OD on alternate days. After that, child then after that 10 weeks 10 months later, the child and she was also given physiotherapy and speech therapy to cope up, and she has been gradually progressing with that. She was initially started on basal bolus regime of 4 units regular insulin on morning, evening, and night, and basal insulin of 4 units. And after that, however, after till date, the brain abscesses have not cured completely, and amphotericin has not been stopped. There have been numerous consultations, and there are also parent concerns regarding the excision of the other brain abscesses, but the neurosurgery team has decided not to operate because of the multiple locations and also the inaccessible operation sites. After that, child 2 months ago, due to her improved MySR record, she prepares home cooked meal comprising of complex starch and lean meat and unsaturated fatty acids, and she takes total of 3 meals per day with 5 snacks, and she is very particular about the exercise as well. Since the last 2 months, her blood sugar, her insulin was decreased down to 2 units TDS and 2 units at night, because her BSR record was between 70 to 120. After that, it remains between the usual 150 to 200. And mother is well aware of the complications of the hypoglycemia. However, none has presented since the onset. Child was born to via SVD in Narowal at a clinic to non-consanguineous parents with no history of gestational diabetes in the mother. There are a total of 5 siblings, and she's second in order. There's one history of earlier death in the family due to conductress at the age of 14. Child is vaccinated as per EPI, and she also received an additional flu vaccine after her diagnosis of the after her diagnosis of the diabetes mellitus. Mother is well aware of her nutrition, and she's very keenly following the recommendations. And her usual intake in the 24 hours is approximately 1100 kilocalories. She is developmentally normal, and she was a student of class 2, but she had to leave school 1 year ago due to her repeated hospital stays and her disease. The disease has significant. Father owns a business of the tiles in the UAE, and mother is the sole caretaker of the family. And the disease has significant psychosocial impact on the family. They are bearing their all the financial expenses of the amphotericin B, the repeated admissions, and the serial MRIs that are done in the narrow wall by themselves with no difficulty. However, mother is complaining about the negligence of her younger children. 3 of them are under 5 years of age, and she has to leave them at different relatives. And also, the child is very much socially withdrawn now. And mother says she does not like to play, and she's very upset about her loss of school. She is well aware of the insulin storage site, its administration, and its complications, and is compliant with the disease and treatment. Shall I proceed
Okay.
with examination?
Yeah, sure.
I, I have examined a 6-year-old girl, Maheen, who is lying on the bed with no obvious distress dysmorphism, with IV line on the left foot and a bandage covering the right eye and the right nose and the half of her face, right side of the face, who is cooperative but socially withdrawn. And her vitals are heart rate of 88 beats per minute, respiratory rate of 26 beats per minute, temperature of 99.8 degree Fahrenheit, and blood pressure of 100 by 60. Her height is 106 centimeter and her weight is 21 kgs, both of which seem to be below for her age, but I would like to plot on these entire charts. On examination, there is no clubbing, pallor, or leukonychia, and there are multiple IV cannulation sites on her body and arms and feet, with multiple prick sites, insulin prick sites and BSR prick sites. And there is no lymphadenopathy. There is no pallor or cyanosis. No thyroid is not palpable. Her chest is symmetrical with normal vesicular breathing and no added sounds. Her heart epic speed is in the fifth intercostal space, just medial to the mid clavicular line. S1 and S2 are audible with no added sounds. And on exam, there are no signs of lipoatrophy or hypertrophy or skin pigmentation. The abdomen is soft, non-tender. There is no visceromegaly. Uh, Kidneys are non-palpable and bladder is also not palpable. SMR are pre-pubertal, and there is no sign of pedal or sacral edema.
Okay. Any other thing you want to tell me?
No, madam.
Okay. Any other examination you want to describe, you want to do in your patient? Okay. Would you like to go for fundoscopy? Would you like to go for
Yes, madam.
fundoscopy? Okay. Why you want to go for
Yes,
that?
madam. Madam, there are multiple brain abscesses. Even though the right eye was removed, there could be some abscesses surrounding the left optic nerve. So I would like to look for that as well.
Okay. So what is the tone of your patient?
Madam, it was normal. I should
Okay.
have
That
mentioned.
was okay. That was bilaterally symmetrical.
Yes, madam.
Okay. Is there any focal sign?
No, no, madam. No focal sign.
Is there any cranial nerve involvement
No,
in your
madam.
patient? Okay. What
No,
was
madam.
the condition of the throat in your patient? How was oral
Mm,
hygiene?
I did not check the throat, madam.
Okay. Was BCG scar present?
Yes, 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 it was present. Yes, it was present.
Okay. Was that present on the right deltoid or left deltoid?
Right deltoid.
Okay. Where she is injecting the insulin? At what area of?
Madam, she is injecting it on the abdomen.
Okay. Who is
Madam,
injecting?
mother is rotating the site circumferentially. Mother is
Okay. Who is
injecting. She is
injecting?
rotating
Okay.
the
Does
mother.
she has knowledge about the insulin storage and
Yes, madam. She has a good knowledge about the insulin storage.
okay, which type of insulin she is giving?
She's giving the basal bolus regime, regular and long-acting basal.
Okay. Is any time your patient had somogai or Dawn phenomena?
No, no, madam.
Okay. Did you assess it?
Yes, madam. The mother says that every time her BSR record was static, and since the presentation, there was one episode of DK at presentation, and now she has presented with DK.
No,
And
I'm asking about the somogai phenomena.
no, no, madam, there was no history of no symptoms of hypoglycemia ever recorded, and she checks it 7 times a day, before the meals and after the meals and at bedtime.
Okay.
So there have been
So
no variations in that as well.
what is the clinical and this lab symptom of this somogai phenomena? Is that hypoglycemia or hyperglycemia?
Madam, hyperglycemia
Okay. At what time?
at 4 a.m. in the morning.
4 a.m. in the morning. Okay. Is there any associated autoimmune disease in your patient?
No, madam. There was no history of loose stools, and there was also no history of heat or cold intolerance.
Did you tell us about that?
No, I forgot to tell it.
Okay. Is there any acanthosis nigricans in your patient?
No, no, there was nothing on examination.
Okay. Is there any hyperpigmentation of the on the body of your patient?
No, madam.
Okay, all right. Why she was having so much multiple brain abscesses? What is the cause for that?
Madam, they said that uh, the it was a fungal infection, and the biopsy for the removed part of the eye it was done, and it showed multiple fungal infections, and
Why that?
they were
Why? Okay, why it is present in your patient?
madam, because she's a patient of DK, and she is immunocompromised and is predisposed to unusual and fungal infections.
How many patients of the DK you have seen with this multiple type of the abscesses, multiple brain abscesses? Okay, when
First
where?
one.
Okay, all right. So anytime your patient was having fits,
No, madam.
that was wrong. Okay, what was the target BSR of your patient? That was decided by the hospital.
Madam, it was yes. So, given her young age, it was decided between 150 to 200.
That was 150 to 200. Okay, so what is the total dose of the amphotericin B she was taking? Currently, she's on the
Madam,
amphotericin
initially
B.
she was taking, yes, she was initially taking, madam, 15 grams, 15 grams OD for the first 6 months. After that, her RFTs became deranged, and it was reduced to 20 grams on alternate days.
Okay, so what was the urine output when the RFTs they were deranged?
Madam, she said that she never experienced any oliguria, but they had monthly RFTs, and that's when it was found that her RFTs are deranged.
Okay, you told us about there was loss of speech in your patient when
Yes,
her
madam.
some okay, why that was present?
Madam, the child is now recovering, so I think, and she was talking as well, so I think it was because the frontal part of the lobe was removed, and she had some behavioral. She was socially withdrawn because
Okay,
she was talking fine, and I don't think so. There was any injury to any part of the cranial nerve, and also the mother says that she is very isolated now. So I think it's because of the removal of that uh, frontal part of the frontal brain where there was also an abscess.
okay. Was she symptomatic diabetic or asymptomatic diabetic?
Madam, she is symptomatic because her infection is not resolving.
Now she's
Also,
symptomatic. When she was first diagnosed, was that symptomatic or asymptomatic?
madam, she did have polyuria, polydipsia, and there was weight loss. However, she did
Okay,
not have the typical DKA symptoms back then, like fever, vomiting, like
okay.
that.
Why did you ask for the bony deformity in your patient?
Madam, mother told me that she just had polyuria and polydipsia and weight loss. So for polyuria and weight loss, I wanted to rule out Bartter or uh, and
And
rickets associated with it.
okay, why asked about head trauma?
Madam, to rule out any cranial pathology for diabetes insipidus.
Okay, all right. So you told what is your differential diagnosis?
Madam, my differential is type 1 diabetes mellitus with brain abscess. And yes, madam, that's it.
Just one day before she developed this fever, vomiting, and high BSR. This
Yes.
is so short history. She was quite all right one day back.
Yes, madam. The mother says that she checks blood sugar 7 times a week, 7 times a day, and she just had a fever and vomiting. And
Okay,
she
so
said
what?
that it started on its own. Sorry.
What is the focus of the fever? What is focus of fever?
Madam, yes, so Madam, I asked about ear discharge or anything, but mother said that there was just slight flu 2 days prior to that,
So
and
what
it
is the
suddenly and the fever was very gradual, and it started to 1 or 2 degree Fahrenheit.
focus of the fever?
Madam, I should have looked for the throat examination. It could be the throat.
Is there any history of the cough?
No, no, no history of cough.
Cough is not present. Okay. All right. You told us your patient that was sent to the hospital, some excessive blood testing that was done. What do you mean by that? Extensive blood testing?
Sorry.
You told us some extensive blood testing was done when
Yes,
patient landed in
yes.
tertiary care. Okay, what do you mean by that?
Madam, blood sugar levels, HbA1c, celiac serology, and then blood cultures. These were done. Serum
Okay,
electrolytes.
okay. So what was the report of the celiac disease in your
Thyroid function
patient?
tests were also done.
Okay, what was the
Madam,
report of the
no
celiac?
associations were found for the sugars and the thyroid.
Okay, that was on the testing, but not
Sorry?
on your clinic. That was on the lab investigations, not on the history, not on the examination.
Yes, madam.
Okay, all right. So,
Sorry.
okay, how will you investigate your patient? How will you investigate? Okay. Uh, are you
Madam,
listening?
I will
Mhm.
first review all the previous labs, and then since my child is now out of DK, I would check for her serum electrolytes for serum potassium, and then I would look out for her RFTs because she has had previous history of derangement of RFTs, and I would also look for her LFTs, and I would also review her BSR records. I would go for the HbA1c. I would go for the MRI brain, and I would look for the extent of the brain abscesses. And I would also do the B scan to look for the left eye functioning as well.
Okay. Any other investigation?
Uh,
Would you like to go for CBC?
yes, madam, I would like to go for CVC because she presented with fever and vomiting. I would look for the urine test as well to look for any focus of infection.
Okay.
Um, and
Blood culture?
yes, blood culture and urine culture as well.
Okay. Any other investigation? What is the role of the
Madam,
serum electrolytes?
to see for hypokalemia and yes, that's it.
What happens to the serum
Also
electrolytes
to
in?
hypernatremia as well.
Okay. All right. Any other investigation in your mind?
Madam, the thyroid test was done 1 year ago, so I would also like to repeat that.
Okay. Any other investigation?
Mm.
Would you like to go for retinopathy assessment in your patient?
Yes, madam. Yes, madam. Detailed eye examination with fundoscopy, V scanning, and the
Okay.
other.
Okay. Would you like to
Um,
rule out nephropathy in your patient?
yes, madam. So I'll look for the microalbuminuria as well, in addition to the
Why?
RFT.
What is the
Madam, because
latest recommendation?
sorry,
When you should screen a patient for this nephropathy?
3 years after the onset of disease, 3 to 5 years.
Okay. Is that 3 years?
I think it's 3 years, 3 to 5 years.
3 to 5 years after the onset of the disease.
Yes, so it's too early for that.
Okay. All right. Any other investigation in your patient?
Um,
Okay. How will you manage your patient?
Madam, I'll involve a multidisciplinary team involving myself, the endocrinologist, the dietitian nurse, and the ophthalmologist and the neurosurgical team. So I would think of a plan for the for the I would also like to do the swab of the orbital cavity to see if there is any resistance to the amphotericin B. And I would like to review that why after 1 year of amphotericin B, her brain's abscess hasn't resolved. And I would add another antifungal as per the infectious disease panelist. And also regarding the we can also have discussion with the neurosurgical team regarding any excision of the remaining parts of the brain abscesses. And her blood sugar levels seem to be controlled, so I would continue with the same regime. And also I would offer her psychosocial support. She is very much depressed. And yes, madam, I will also consult the nephrologist for the for further follow-up of her renal scarring or any other complication that might have developed due to prolonged use of the amphotericin B.
Okay. Any other discipline you will involve in your case? Is there any role of
Madam,
immunologist?
sorry,
Is any role of
immunologist?
immunologist? Yeah. Their
Yes,
patient?
madam, we could definitely have an
Yes.
assessment of her. Hello,
या listening. जी बताएं.
madam, immunologist पूछ रही हैं आप?
Yes. Is this a case of
Yes,
immune
madam.
deficiency?
Madam, we could definitely check for some secondary immunodeficiencies, but over this period, the mother says that she just had one episode of DK at the birth, at 1 year ago, and now she presented with DK, and between that there was no symptoms related to diabetes. So yes, due to her prolonged standing brain abscess, that is not deep-seated abscesses, brain abscesses, that is not responding to the amphotericin B despite a year of treatment. So yes, it could be some secondary immunodeficiency. I would like to extend my workup and include causes of secondary immunodeficiency as well, like hepatitis,
Yes.
like HIV and tuberculosis. And
Yes.
yes, sorry.
Yes, Shabash. Now this is the point. You should extend your differentials, that is for the immune deficiency. Yeah, that may be due to this diabetes, but so much multiple brain abscesses they are present. They are not responding to the treatment. You should consider HIV. You should consider other immune deficient diseases. Okay.
Yes, madam.
Okay. So you will involve infection disease specialist. You will involve immunologist. You will involve ophthalmologist. Okay. And
Madam.
tell me about your further management.
Madam,
Yeah.
um, we'll investigate for any immunodeficiency, and we'll give treat the cause of the secondary immunodeficiency if it's present. We can see for the immunoglobulin subsets and replace if there is any decrease in any of the subsets. Also, madam, after the discussion with the infectious disease specialist, we can and the multiple culture swabs of the eye cavity, we can add additional drugs in addition to the amphotericin. And if it's not, if the disease is resistant to amphotericin, we can withdraw it completely. And we can have a discussion with the neurosurgical team regarding the excision of the brain abscesses, because as long it's present, the child will continue to have these symptoms. And
Okay.
yes, madam, we can just have a discussion with the endocrinologist as well regarding the current BSR regime. However, her blood sugar levels seem to be controlled.
Okay. What was the insulin sensitivity factor of your patient?
Madam,
How it
I
is checked?
don't have knowledge of that.
Okay. Okay. So you don't know how. Okay. What is insulin carbohydrate ratio for the management of the diabetes? Now we are talking about the diabetes. So
Yes,
what?
madam, I don't know.
Okay, you don't know. All right. Will you counsel the parent?
Yes, madam. I'll counsel the parent and I'll offer the mother psychological support because she was very much depressed, and I'll counsel her regarding the disease, its complications, and the
So you will involve psychiatrist and
yes,
psychologist too.
yes, both for the mother and the child.
Yeah. Now tell me, you will involve multidisciplinary approach. Name all that disciplines
Okay.
again.
I involve the multidisciplinary team involving myself, the pediatrician, and the infectious disease specialist, the endocrinologist, the ophthalmologist, the immunologist, the dietitian, the
Mhm.
physiotherapist, the social support, and the child and adult psychologist. Yes, all of these.
Okay. All right. Now I'm coming to some Viva questions, right?
Mhm.
You told me about the target BSR of your patient. Was that well maintained in your patient?
Yes, madam. The mother said that she used to check it herself 7 times a day, three
Mm-hmm.
times before meal and three
From
times
where
after
they're
meal.
okay, from where they're getting these BSR strips.
Madam, the mother said that they are well to do and they manage all their expenses on
Okay,
themselves. Even the monthly MRI, they get it done from Narowal because mother has difficulty in
okay,
traveling because of the younger kid.
okay. So what are the
So
complications of the orbital
she
cellulitis?
even pays for MRI scans as well.
Okay. What are complications of the orbital cellulitis that can be
She's
present?
also suffering from sorry. Madam, complications of orbital cellulitis, they include ophthalmoplegia, visual loss, and squint, and fever and a brain abscess if
Are
it's
these
spreading.
complication of orbital cellulitis? Are these presentation of the orbital cellulitis? Ophthalmoplegia is a complication or presentation?
Presentation.
Okay,
Madam,
so
complications, they include brain hematogenous spread into the brain,
okay.
so due to brain abscesses.
Brain abscesses. Number one, that is the brain abscess. Number two,
Yes.
now
Madam, it could also lead to the paranasal sinusitis.
can this lead to this cavernous sinus thrombosis?
Yes, madam, cavernous sinus thrombosis as well.
Okay. So how will you manage that if it is present?
Madam, for the cavernous sinus thrombosis, we give broad spectrum antibiotics. We will give heparin, and we will remove we will remove if there is any superficial abscess present as well.
Okay, just 1 minute. May I call it? Okay. What are the latest modalities of the insulin which are present now? Do you have any knowledge about the inhaled
No, madam.
inhaled insulin?
Sorry?
What is your knowledge about the inhaled insulin?
No, madam.
Vaccination that is okay. Okay, all right. So okay. चलें जी अब एक्सप्लेन करते हैं व्हाट इज डॉन फिनोमिना एंड व्हाट इज सोमोगाई फिनोमिना ओके द मदर इज कमिंग टू यू right she's telling me your patient is having her baby is having early morning hyperglycemia सुबह के वक्त की शुगर जो है दैट इज ऑलवेज इंक्रीज ठीक है write down one line what is dawn phenomena that is an exaggeration of the normal physiologic phenomena that is present in the diabetic patients. So, what is that normal physiology? In the midnight, there is increased excretion of the insulin from the body. Okay, are you listening?
Yes, madam.
Okay, Dr. Amna, please write the this line that is very important. This is exaggeration of the normal physiologic phenomena that is present in the diabetic patients. Every person that is having increased excretion of the insulin from the body in the midnight, and that is exaggerated. So all the patients they have hyperglycemia in the midnight, okay, and that is also causing hyperglycemia early in the morning. ओके, समझ आ गई? प्लीज
Yes, madam.
रिस्पॉन्ड करें। ओके,
Yes,
सो
ma'am.
इन द डॉन फिनोमिना मिडनाइट पे क्या है? हाइपरग्लाइसीमिया। अर्ली इन द मॉर्निंग क्या है? दैट इज हाइपरग्लाइसीमिया। ओके, सो व्हाट इज द मैनेजमेंट? What is the management? Increase the dose of the nighttime insulin. आपने इसमें जो वर्ड याद रखना है that is rise. So increase the dose of the basal insulin, that is the rise. There is rise in the blood sugar level in the midnight. There is rise in the blood sugar level early in the morning. So in the dawn phenomena, everything we there is there everything that is on the rise. Okay. In the somogai phenomena, what is going to happen? I have given the insulin that was in the increased dose. Increased dose of the insulin that is being given. What will happen in the midnight? There will be hypoglycemia. To counteract, there will be release of these counter regulatory hormones that will cause early morning hyperglycemia. You got my point, Dr. Rabia?
Yes, ma'am.
Okay, now Rabia, you will tell me what is Somagai phenomena and what is dawn phenomena. Very quickly और आसान से लफ्जों
Uh,
में.
Ma'am, in dawn phenomena, due to insulin clearance, there is
Yeah,
a recurrent exaggeration of the normal physiological phenomena and increased secretion of the insulin from the body. So
yeah,
that and there is early morning hyperglycemia. So we treated this patient by increasing insulin dose at night, mainly
yes,
long acting.
yes, yes. Okay,
And
and what?
in somagoid phenomena, due to the increased insulin given at night, are due to the regulatory hormone, a rebound
No,
phenomena
no.
from the
Due to increased dose of the insulin, it will cause
given at night time.
hypoglycemia.
Night
Okay,
time, it cause hypoglycemia and increased blood sugar level in the morning, and it is treated by decreasing the insulin dose at night.
okay, ठीक हो गया. All right. So, Dr. Vania, for you, please, you must know. Okay, now we will talk about the insulin sensitivity factor and insulin carbohydrate ratio. Okay, when we are going to manage any patient of the diabetes, we must know these two factors. So, what is insulin sensitivity factor? Anyone of you will describe this? Dr. Nimra, Dr. Amina Mirza, you just have prepared, I think, this case. Please do tell me what is insulin sensitivity factor.
Ma'am,
Insulin,
can you hear me now? Hello?
What is insulin sensitivity factor?
well, it is
Ma'am,
an
basically,
expected fall in BSR with one unit of insulin.
Sorry?
It is the expected fall in BSR with 1 unit of insulin.
Very good. So how much glucose that would be reduced by 1 unit of the insulin? Okay. And what is insulin carbohydrate ratio?
And it is a number of units of insulin that are required to cover one carbohydrate meal. And one carbohydrate meal contains approximately 18 grams of carbohydrates.
Okay. So how will you assess, how will you calculate insulin sensitivity factor and how will you calculate this insulin carbohydrate ratio?
And insulin to carbohydrate ratio is calculated by 500 divided by total daily dose of insulin.
Yes. And what about insulin sensitivity factor?
So I don't know what to do.
That is,
1800 divided by total
yeah,
dose.
it is 100 divided by total daily dose. Okay, all right. So now please calculate. This will be asked in your examination. The child, what is the target BSR of your patient and how you will manage the sugar of your patient. So the pre-meal glucose of a patient, suppose that is 100 millimoles per liter, sorry, 10 millimoles per liter. Okay, and the target BSR of your patient that is 5 millimoles. Okay, so how will you calculate the total daily dose of your patient? That is, suppose that is 10 units. Okay, now you must know, you should calculate how you are going to give insulin to these patients. You what is the amount of the basal bolus? That is almost the 50% of the total daily dose. How to calculate this total daily dose? That is, suppose that is 0.7 to 0.1 units per kg. it comes out to be 10 units. So 10 units is the total daily dose of any patient. I will give 50% in the form of the basal bolus, that is the 5 units by this basal bolus. The rest of the units that will be given during the whole day. How that is given? For that, we will check the pre-meal insulin, this blood sugar. Okay. So please do remember, it's not only the blood sugar that is being managed. It is the sugar that is present in your blood. It is the sugar that is present in your meal. So some units of the insulin, they will be given for the blood sugar, that is known as the correction dose, and some units of the insulin, they are given for the management of the sugar which is present in your meal. Okay. Okay, now for the management of the sugar carbohydrate that is present in the meal, I will assess it, I will calculate it by the insulin carbohydrate ratio. Okay, Dr. Amina, tell me how will you calculate that? My baby wants to eat this Lays chips, and over here it's always written the carbohydrate amount that is, suppose that is 30 grams. So what amount of the insulin you will give?
Uh, Ma'am, I will calculate the total daily dose and then minus this 30 grams from the daily dose. Hello?
जी जी मैं सुन रही हूँ.
जी ma'am, I will calculate the total daily dose and will subtract this 30 grams from the dose and then divide it on the 450 or 500.
नहीं डॉक्टर आमना, मुझे बताएं, इसको आपने इंसुलिन कार्बोहाइड्रेट
मैडम 2 यूनिट चाहिए होंगे.
मैम प्लस 2 यूनिट्स उसमें तो ऐड करने ही होते हैं, लेकिन इसको कैलकुलेट जो है मैम वो ऐसे ही करेंगे. अगर डेली डोज जितनी भी हमारी बन रही है उसमें से आपने जितनी भी के कार्ब्स के ग्राम्स बन रहे हैं उसको सब्सट्रैक्ट
फार्मूला
करके
क्या है डॉक्टर आमना, उसका फार्मूला क्या है?
मैम 450 डिवाइडेड बाय टोटल डेली डोज.
suppose like that is 500 divided by total daily dose. ठीक हो गया. इसका ये
मैम
मतलब है कि जो भी इसका आंसर आएगा, 1 unit of insulin will decrease this much amount, that will be used for this much amount of the carbohydrates. Just uh, I'm sorry. Okay, so Dr. Amna, please tell me. I'm sorry, वो जरा मेरे बच्चे आगे थे. It was 500 divided by total daily dose. What is coming? It will tell you 1 unit of insulin will be used for this much amount of the carbohydrates. Suppose it comes out to be 15 gram. Okay, so this Lay's packet that is having 30 grams of carbohydrate, I will use 2 units of the insulin for this meal that is being given to this child. Okay, so this amount of the insulin that is for the meal, my blood sugar, my baby's blood sugar comes out to be 10 millimoles per liter, but my target BSR of the baby was 5 millimoles per liter. Just